COVID-19. Today we will present part 2, protocols to clean and disinfect in the COVID-19 environment. The highly transmittable nature of this novel virus and the exposure risk associated with it are evolving daily. Understanding the most recent updates on COVID-19 is essential as we implement recommended processes and procedures from government and regional health authorities for hand hygiene and the use of personal protective equipment, or PPE. These recommendations will provide maximum efficacy against the virus while maintaining a safe environment for our staff, patients, and customers. The learning objectives for today are posted on the screen for your convenience. Participant lines have been muted. Unfortunately, continuing education or CE credits are not available for this event due to the limited time to obtain approval in this evolving COVID-19 situation. We'll be hosting another webinar tomorrow, April 1st at 11 a.m. Eastern Daylight Time. The webinar topic will be N95 respirator use, disinfection, and reuse, what the literature says. My name is Dr. Katie Morales. I'm a professor of nursing at Berry College. This presentation will last approximately 50 minutes, followed by 10 minutes for questions and answers. Please type your questions in the webinar panel labeled Q&A. We will follow up after the webinar to address any questions we are not able to answer during the webinar. By participating in this webinar, you acknowledge that the statements and information provided is for general guidance purposes only. The coronavirus situation is evolving and dynamic. You are advised to contact your local government and regional health authorities for specific instructions on all the topics mentioned in this webinar. This webinar is not to replace the guidance and direction of your local government and health authority. The webinar series is hosted by TIPS, a not-for-profit organization existing to advance innovations, ideas, and processes which make a difference in global health. TIPS extends to over 30 countries and is the key strategic partner for many notable organizations, initiatives, and events. In the past few years, TIPS has contributed millions of dollars worth of scientific impact through various programs. Many of their successes are published on their open access journal, www.infectioncontrol.tips, showcased at conferences such as hitsconsortium.org, and on their masterclass events such as master series events, or discussed on their podcast series, deepdive.tips. The webinar series is sponsored by Lighthouse Healthcare. Lighthouse Healthcare partners are subject matter experts in cleaning and disinfection. Their professional team of account advisors, trainers, and retention specialists have over 250 years combined experience in the industry. They specialize in evaluating existing processes, identifying areas for improvement, and recommending customized environmental infection prevention programs. Their solutions are built on 3 pillars: people, processes, and technology. Without further delay, let me introduce today's speakers. First, Dr. Rodney E. Rohde. Dr. Rohde is a professor, associate director of the Translational Health Research Center, and research dean and chair of the Clinical Laboratory Science Program in the College of Health Professions of Texas State University. His background is in public health and clinical microbiology. His PhD dissertation at Texas State included MRSA, knowledge, learning, and adaptation. He's an advisory board member for infectioncontrol.tips. Next, Mr. John LaRochelle. Mr. LaRochelle is the founder and CEO of Environmental Infection Prevention Incorporated and president of Lighthouse Healthcare Partners. He spent over 30 years with Sodexo. He is responsible for program development and technical support of 600 healthcare locations in the U.S. He has expertise in environmental infection prevention and the ability to establish productive collaboration with key stakeholders to impact change. He is also an advisory board member of infectioncontrol.tips. Today's webinar includes audience polling questions. Your answers are anonymous. The first one is designed to help us get to know you better. Please tell us what your role at work is. Thank you for participating. I will, I will turn it over to Dr. Rohde.
Good afternoon, everyone. It's a pleasure to welcome you back if you were at our part 1 series, and if not, welcome to this second series today to discuss this important topic. Today in this session 2, we're going to be going over these primary points. We're going to give you a status update. We're going to do a quick PPE review, followed by a quick hand hygiene review, and then we'll move into more detail along the common failure points in the cleaning and disinfection process, as well as effective cleaning and disinfecting processes. So this virus, which is known as SARS-CoV-2 and the illness as COVID-19, is primarily a respiratory illness that can spread person to person. This group of viruses are responsible for about 25% of the cases of the common cold. We know now that it is very contagious. We know that most coronaviruses are transmitted between animals and humans. These types of infections are typically referred to as zoonotic infections. Most scientists believe that this particular virus made the leap to humans around mid to late December in Wuhan City, China. And this particular virus is the 7th in this group. There are 4 common cold viruses: SARS, which popped out in 2002 and 3 and had a fatality rate of around 10%. And then MERS, Middle Eastern Respiratory Syndrome, was more in 2012 and 13 and had a relatively high fatality rate around 30 to 35%. What we know about this virus is changing daily, but according to the Centers for Disease Control Director, Dr. Robert Redfield, in a recent NPR interview, he stated that COVID-19 is roughly 3 times more infectious than flu, and 1 in 4 Americans are asymptomatic. So approximately 25% of individuals out there in America, we think, are asymptomatic at this time. He also stated that he believes that the virus may be shed about 48 hours prior to symptoms. This spread, we believe, is happening within close contact. Thus, that is why social distancing is so important. Within about 6 feet is thought to be the kind of frame of reference to keep individuals away from you. The virus is spread primarily through respiratory droplets. That's when you sneeze or cough or even talk. And if you can visualize kind of a fine mist coming out of your nose or mouth and that being projected outward up to 6 feet, especially on cool days without much humidity, it's shown that respiratory droplets spread even more quickly. We believe now that we're seeing survival rates in the air for up to 3 hours. And like many viruses, this one is thought to survive for 3 hours and up to 17 days based on a very current study. That is why it is so important to be aware and diligent of high touch surfaces with your hands, including gloved hands. And then if you went and touched your mouth, your nose, your eyes, and things like that, you certainly are providing a route of transmission for this virus. And we also know now that community transmission is occurring in the United States. And that's basically what happens when you have this type of spread to unknown areas, unknown sources, and new areas as it moves through the population. Treatment-wise, right now, it's primarily supportive care. So if someone succumbs to more dangerous types of symptoms with respect to pneumonia, you're going to receive fluids, O2, and ventilator support to help you exchange that oxygen because your lungs typically are being filled with fluid. As of now, there is no vaccine currently being used, but there are multiple vaccines that are being looked at. Hopefully within the next 12 to 18 months, we will have that particular research kind of coming to fruition. And lastly, there are some research and clinical trials in progress with respect to different types of antivirals and different types of possible drugs that might be useful. Here is a snapshot as of today of what's going around globally, as well as in the United States. There are currently, today actually, we kind of hit another milestone globally. We reached 800,000 cases, so we're certainly approaching that 1 million mark. You can see the deaths are approaching a little over 39,000. If you do the quick math on that for a case fatality rate, and again, remembering that this CFR, this fatality rate, is going to kind of be a range as case data and testing changes over the coming days, weeks, and months. Right now at this snapshot, it's about 4.8%. In the US, we've reached over 160,000 cases with about 3,100 deaths, and that is roughly about a 1.9% case fatality rate. Again, that agrees with the CDC director mentioning this particular virus is about 3 times more fatal than the flu. Here's our second polling question. We're going to follow that up at a later time when we do them together. So what do we do with personal protective equipment? Personal protective equipment, one quick reminder before we get into a few specifics, is that PPE is obviously ongoing and recurrent. PPE is only as good as the user. So who should be using PPE? Basically, when you have direct or indirect exposure to the following types of situations: body substances, different types of medical supplies and devices and equipment that is contaminated, the variety and diverse number of environmental surfaces in both healthcare but also in other environments, and then even with respect to contaminated air. What's required for PPE? Certainly in healthcare, when you're dealing with patients and those who are either positive for a particular agent, including this one, and are under suspicion for being positive, typically you're going to gown up. You will be using a mask or a respirator at the level of N95 or higher that is NIOSH approved. In many cases, goggles and face shields to avoid splashes and things like that from getting in your eyes. And then, of course, gloves. If you are in a non-healthcare environment, certainly that becomes important as well with respect to what area you're cleaning and what's going on with respect to an agent. The gown, the respirator, again at an N95 or higher rating, goggles and face shields again, and gloves. Basically, what we need to keep in mind is that if there is any doubt that you're working in an area that is contaminated with an agent that could become infectious to a human being and could become dangerous, especially those things that are not treatable or are vaccine available, then you need to be using that N95 respirator and taking care of yourself. As a quick review, we went over this last time, so you can go back to that particular part 1 if you want to have more details. But typically PPE is going to go through a process of donning with respect to the gown, the mask or respirator, the goggles or face shields, and then gloves. It's important when you're doing this to keep your hands away from your face, being very aware that you're not touching surfaces or very limited surfaces, and to change your gloves when they're torn or heavily contaminated. And then it is always good practice to perform a hand hygiene as you're moving through and after this process. Doffing or removing PPE, again, this is one example. These particular visuals can be found at CDC. There are many others from other professional and reputable sources that you can find, including videos and the sorts. Typically, you are going to start with gloves. You basically, as you move through this, you're going to remove all PPE before exiting the patient room except a respirator. After the gloves, and you can notice that there's a particular way to remove those gloves to avoid contaminating your hands. And through each step, you're going to discard what you can into a proper waste container, followed by goggles and the face shield, being careful again to watch your hands and other parts that you're touching on that face shield, followed by the gown, where you are going to pull the gown away from your neck or shoulders and remembering that the front of it is the primary contaminated surface, and you're going to roll that into a bundle and discard it into a waste container. Again, the mask or respirator is typically left on until you leave the room. And then when you're removing that mask or respirator, you're going to be very careful not to touch the front, and you're going to just grasp the elastics or the ties and remove it carefully. Last but not least, and this holds true all the time, is washing your hands and using alcohol-based hand sanitizers immediately after removing all of the PPE. If in doubt, wash your hands or use an alcohol-based hand sanitizer between the steps and immediately after. What about hand hygiene? I typically like to discuss this with respect to any healthcare professional and other, including EVS professionals, about these invisible pathogens. Surfaces really do matter to everyone all the time. We cannot see these pathogens. They are at a level of microscopic size that you cannot possibly see them with your eye. So even if a room looks clean and smells clean, you do not know if it is microbially clean. So this is not just a healthcare problem. This is also outside of that realm. This is the typical way to hand wash. I'll show you a short video momentarily, but typically you want to make sure that you're cleaning the entire hands, whether you're washing or using a hand sanitizer. Notice the time allotment can approach a half a minute up to a minute. And when you look at the data of hand hygiene, most of the time people do a good job of cleaning the palms of the hands. What you really want to pay attention to in these processes is going through the steps and kind of practicing them so that they become muscle memory with respect to getting the fingertips clean. The thumbs are problem areas, and the back of the hands. And so it's very important to make sure you're getting full coverage as you go through this process, and to do it often. Let's check out this video that kind of shows this particular process. The user's using a paint compound that does a great job of showing you how you can miss areas. The gloves have added effect of showing you how important it is to move to your fingertips. We obviously started with the palms, the backs of the hands, and now the thumbs are being shown as they're cleaned. If you don't do this process completely, you can certainly leave surfaces of the hand and fingers prone to infecting others or contaminating other surfaces. So what about some of the disinfectant use on microorganisms? We went through this a little bit in the last series, but if you look at the graph and you see on the far left there, the S stands for a sensitive. So the virus is more sensitive to the disinfectant or the cleaning agent. And as you go up to the red on the arrow, it's more resistant. So notice that coronavirus is down at the bottom. These are included in a group of viruses that are known as being enveloped, which means they have a very lipidy or fatty process around the nucleic acid. This actually makes this type of virus quite fragile. So this is a good thing for the particular coronavirus we're worried about. Notice influenza and some of the other notorious viruses like HIV and so forth are also quite fragile to disinfectants and cleaners. As you go up the scale, you'll go through a variety of the different microbial groups, including gram-positive and gram-negative bacteria. Non-enveloped viruses are a little more resistant. Then you get into the more resistant things like fungal spores, very small non-enveloped viruses. Norovirus is that virus that you sometimes hear about on cruise ships or in daycares that cause rapid diarrheal illness. Everybody knows about tuberculosis. That is a true airborne type of bacteria that has a very waxy, thick cell envelope that makes it quite resistant. And then at the top of the list are those spore-forming bacteria, such as C. diff or Bacillus anthracis, which causes anthrax. So you have to pick the right tool for the right job when you're moving through these types of agents. Cleaning and disinfection is obviously critically important. The visible soil and dirt, body fluids, or other organic matter must be removed prior to disinfecting. If you do not remove those visible particles and soils and other things, then it can hamper the effect of the actual disinfectant. And just doing that first will also help reduce the risk of spreading the infection. Then that is followed by disinfection, which is reducing the number of pathogenic microbes to the point where it can further lower the risk of spreading any type of agent that might cause an infection. Products that work against COVID-19 or SARS-2 can be found under the N list. And if you see that link, you can check that out on your own. And on the right side of this slide, you can see what is critically important as you go through this process for the N list. We always talk about following the directions. I go over this with my students and with other colleagues and family members that sometimes just pick up a product and use it without really paying attention to what it's useful against and what it is going to work properly for the dwell time or how long that product should stay on the surface you're cleaning, and any number of other issues around using it, including temperature and all sorts of things. So if you read through this process, I won't read it directly to you, but you want to make sure you look for the EPA registration numbers on the label and then compare it to that on the product label with the EPA registration number on the list, that N list, and just make sure that they are matching up correctly. And you can always check on that by seeking more information either through the product or the EPA list. Now we're going to transition to my partner, John LaRochelle.
Okay, Rodney, thank you very much. Great presentation, appreciate everything. So wanted to talk to everyone today about kind of where we are. And we're going to start with some polling slides. We'll see if those, we can get those up. Okay, looks like we're having a little technical difficulty with our polling, so we'll try to get back to this later. So again, my name is John LaRochelle, and this is, today's topic is critically important for everybody to understand that we're virtually at a war. We've had a war on terrorism. We've had a war on drugs. This is a war on pathogens. It's real people, real lives, and real impact. And we have to continue to understand exactly what our roles are and protect all of us collectively and individually. So to focus on, we're going to go through a lot of different components today. I'm going to move as rapidly as I can. But essentially, the challenge that we're facing today is that we've been cleaning virtually the same way for over 50 years. And I've worked as a housekeeper in just about every industry, whether it be schools, colleges, elder care, and hospitals. And I can tell you, a lot of things have not changed. And we're going to focus a lot on that. But I'd like you to bring you back in time to 9/11 and focusing on what happened after 9/11 as it related to air travel. Now, I traveled quite a bit, and before 9/11, there were very little lines for TSA. But now, since that tragedy occurred, it's very acceptable to stay in longer lines, to go through this complicated process, to have the right ideas. So I want you to kind of think of that same concept as it relates to COVID-19 and cleaning and disinfecting in general, because COVID-19 is here today, but we're still dealing with over 200 deaths every day from other infections. So we must change our approach to cleaning and disinfection. Every aspect needs to be looked at, and every aspect needs to be understood and brought to everyone's attention. And we'll kind of cover some of those today. We can't get to them all, but we'll certainly try to get to the majority of them. First and foremost, the heroes of this fight are the cleaners. the environmental services workers, the housekeepers, the janitors, whatever you want to call them, they're the tip of the spear in this war. They're the ones on the front line cleaning every day, and we got to get them the right products. We got to follow the right process, and we got to celebrate them every step of the way. Tragically, Dennis Dickerson lost his life March 26th. He was an NYPD custodian, and this is just, I'm sure, the first of many of people that are on the front lines. I don't know the exact situation of this tragedy, but I can tell you that talking to colleagues, talking to people around the country, we're not doing enough to protect our cleaning staff, and let's focus a little more on what some of the things are that we can do that. So we must change how we look at environmental services staff. They're risking their lives every day. They're on the front line, and a lot are simply not getting the personal protective equipment that they need. Whether they be in a hospital, whether they be in an office building, we share equal risks in varying degrees. They're responsible for the health, safety, and cleaning and disinfecting our environment. They are absolutely the lowest paid employees in the building, and most of them are overworked. So I would ask everyone individually to look at these groups of people and understand what they have and how they're doing it. And we'll kind of get into now, what are some of the failure points? What is the science and research telling us about this challenge, and how do we fix it? So to understand this, you have to absolutely look at all the aspects of the environment, whether it be hand hygiene, surface disinfection, air, enhanced disinfection. You got to look at everything together, and it has to be people, process, and technology. And all those combined, it's simply like a recipe. If you don't follow a recipe when you're baking a cake, if you skip an ingredient, you don't use the right ratio of ingredients, you're not going to get the same outcome. The same is true for cleaning and disinfection. And so we'll talk a little bit more about that. So let's talk some of the challenges that are out there and that the science is telling us. So this is a study done by Dr. John Boyce. He was studying the effectiveness of how many pathogens were on a surface before cleaning. So this is a simple Petri dish view of before cleaning. Now, amazingly, what Dr. Boyce and his team found was that the problem actually got worse after cleaning. There were more pathogens present. This really became the foundation of everything that we've worked on and started to understand that the people, process, and technology was flawed. It's not one thing. It's a host of different things that we have to focus on. We have to understand that pathogens simply live a long time. MRSA, a simple staph infection, whether you're in a high school gym or a hospital, can live on a surface for 9 months. COVID can live up to 17 days. So understanding how long these pathogens can remain active and pathogenic is critical. And this is something that we all need to understand next, is one of the reasons why is dry surface biofilm. The new research all indicates that biofilm is generating on the majority of surfaces, up to 90% of the surfaces in our environment. So Dr. Karen Vickery did a study and showed that how prevalent this was in medical facilities. And this isn't just a medical issue. This is in every facility. So the way this works is a group of unrelated organisms, you see it on the left, kind of work together to create a place to live in. And they create that protective environment that shields them from certain disinfectants that you might use. Up until this year, there was only one disinfectant that was even approved for being effective against biofilm. So understanding the process that you have and whether the disinfectants that you use are actually effective against biofilm will be critical in your understanding. So this is another study done by Dr. John Boyce and a host of others, where they looked at quaternary ammonium disinfectants. Now, what Dr. Boyce did is he filled up a bucket of disinfectant, and they submerged cloths in that, mops and cloths in that disinfectant, and pulled them out one at a time in 5-minute increments, and then rang it out individually and tested how much parts per million of disinfectant was left. Amazingly, the graph on the right shows within 30 minutes, the microfiber cloth had 0 parts per million. You were essentially cleaning with the equivalency of water. The reason why this is occurring is something called quat binding. This is why your fabric softener works in your laundry. We are laundering our clothes, and the clothes, we've added fabric softener to it. That's a quaternary binding effect, and it smells nice and soft. That's what happens when we submerge different mops and cloths into quaternary ammonium disinfectants. So you got to understand not only the chemical that you're using, but the substrate or the wipe or mop that you're using. Another challenge with reusable mops and cloths is they can come back from the laundry contaminated. In this study done by the University of Arizona and Dr. Charles Gerber and that team, they showed that there was a significant amount of contamination when mops were being laundered at a non-commercial facility. Maybe it was this is actually a Boston hospital that was laundering their own in a commercial laundering process, but it still came back contaminated. So it's something you want to look at. And it's a catch-22. If you're sending your mops and your cloths out to a big company like a Cintas or whatnot, they're probably absolutely removing the pathogens because they're going to wash them at extreme high temperatures and dry them at extreme high temperatures. But the problem is, on the left side is a perfectly new microfiber. On the right is one that's been damaged from washing and drying. So it certainly has lost its effectiveness. As we talked about last week, floors are absolutely a transmission mode for pathogens to surfaces. So this was a study done by Dr. Curtis Donsky and his team. They inoculated floors and then watched the spread of pathogens over time. And within 2 days, this is a patient care environment, 62% of the patients had the pathogen from the floor on them, and 62% of the surfaces. I can tell you from experience, the majority of hospitals do not use an EPA-registered disinfectant on their patient room floors on a daily basis. This is a practice that must change. So let's talk about some of the best practices. It's not all-inclusive. This is just a sample of some of the ones that we've pulled forward, and we'll kind of go through them individually. But to start, we have to understand the 5 rights. We need to have the right qualified staff. Is the employee trained to do the job that we've asked them to do? If they're in a school and we've asked them to go into a dorm that had a confirmed COVID case, does that person have the right training? Are we using the right products from the N list? Are they compatible? Are we using them appropriately? Are we following the right process? Because again, it's a recipe, and cleaning and disinfection are 2 separate steps. We have to have the right frequency. A lot of the frequencies are being updated, and those high frequently touched items, such as doorknobs, need to be increased in frequency. And then we have to have a right validation process. So disinfectant guidelines are a key thing. Rodney touched upon it in terms of which ones and how to get them from the N list. So that is a process that you need to go through. You need to select the N list that has an emerging pathogen claim. You need to focus on the dwell time. If it says it needs to stay wet for 10 minutes, that's what's required. And if it says 10 minutes, it's really not realistic that you're ever going to achieve that. And you need to look for a disinfectant that has much less, probably 4 minutes at max. You want to know that the disinfectant is safe for both your staff, your patients, your family, and on the surfaces. We need to follow the EPA label exactly how it's been designed. So if the EPA label says this is spray application only, you are not allowed by the federal mandate and EPA guidelines to use that disinfectant in a bucket method. It has to be sprayed, let stand for the amount of time that it says, and then you can wipe it free. Using it any differently is breaching that guideline. We need to use it on floors. We showed earlier from the Donsky study, the pathogens go from the floor up to the surfaces in any type of environment. You have to focus and understand this. And is your disinfectant effective on biofilm? If it's not, you should look for ones and options that are, because this is a critical pathway for these pathogens to survive and maintain. So we have to be continuously looking at the best practices and the best products. So cleaning and disinfection in the COVID-19 environment. CDC recommends, or recommendations versus best practices. I would ask everyone to simply use common sense. The CDC is a great organization. However, a lot of their guidance has to be based on proven, beyond a reasonable doubt, outcome studies. And with situations like emerging pathogens as COVID-19, you have to use common sense of what you're seeing and what's happening in the environment, and then apply that to what you're going to do for your cleaning practices. And we'll talk a little bit more about that. Do not bring SARS-CoV-19 home with you. You know, employees should change their uniform at the start of shift and change back before, you know, especially if they're exposed to, you know, soils and conditions. You know, wearing the uniform home is not recommended whatsoever. We got to understand the areas of responsibility. Who is cleaning COVID-19 areas? Whether it be a school, a college, you know, who's responsible for what? Who's responsible for the workstations, computer tables, the various pieces of equipment? If you haven't delineated the level of responsibility of who does what when, then someone's going to miss certain key items and think, wow, I thought the teacher was responsible for the computer. I thought the nurse was responsible for their workstation. Understand that, list it, and list out exactly who's responsible. This is a critical aspect. You need to complete a risk assessment. OSHA has guidelines, but basically, what are your risk factors in your particular area? Whether it be a school, a college, or a healthcare environment, understanding where are the risk factors, where are the key populations that are confirmed, suspected confirmed, and what is your exposure risk? Do you have a risk of, in your normal routine of working and cleaning, is there going to be a splash risk where you would need goggles or a face shield? Are you doing tasks performed that will aerosolize the pathogen? And then lastly, what are the air exchanges and how does that impact your whole environment? So we talked last week about, you know, when to wear an N95 mask, and here is the CDC delayed entry guidance to say how long you should wait before and how many air exchanges need to occur before you can re-enter the room. I would challenge you that when in doubt, and if you can't absolutely validate this, you should wear an N95. Personally, our housekeeping jobs, we aerosolize things every day. So we're doing linens, we're doing various tasks, things are getting airborne again. Better safe than sorry. So let's kind of go through the whole process of cleaning a COVID-19 environment. Doesn't matter what environment you're in, whether, again, you're in a corporate environment, a school, a college. If you have a confirmed case, you have a confirmed individual or occupant that has had this, then you need to follow and think of these steps as you're going through. First and foremost, you got to perform hand hygiene, the beginning of and end of every process. Hand washing is the best. If you can't, hand sanitizer. Personal protective equipment, PPE. When in doubt, wear N95. You got to wear gloves, gown, and N95 masks. You have to use goggles when there's a risk of splashing or spraying anything. If you're doing any type of spraying and you're doing any type of activity where this could spray back in your face, you absolutely should have goggles or face shield on. You have to clean and disinfect, okay? They are two separate processes. We'll talk about in a second. But you need to carefully remove all linens and waste, okay? Making sure that, you're not, shaking the sheets or pulling down the curtains. Whatever you're doing, try not to re-aerosolize these things. And that's why an N95 is critical for housekeepers in most operations. High dusting or dusting of any nature should be only damp dusted. So it needs to be saturated with a disinfectant, and that's the only way you should be doing any type of dusting in this environment. You need to clean, then disinfect. So cleaning, as you remember, is removing the gross soils, and then you can disinfect. It's the most missed step in the process. And also, it helps to break down the biofilm to allow the disinfectant to work. So you need to use single-use wipes with an N90 or a List N disinfectant. So single-use is going to give you the best opportunity for the disinfectant to work without clot binding, and it's going to be applied more evenly, and then it's going to be disposed of. You have to focus on the frequently touched surfaces, doorknobs, computers, light switches, things people touch the most. That's what you got to focus on. You have to wipe all surfaces, but those are the ones that, especially as your frequency increases, you want to be redoing those as many times as possible, especially in those high traffic areas. You want to use single-use dry mops. Ideally, this is, again, just like the cleaning and then disinfecting phase, dry mopping the floor with a single-use microfiber is going to remove the gross soils, the debris, and it's going to start to scrape away the pathogens. So then when you go to a single-use damp mop with a disinfectant applied, you're absolutely going to give that disinfectant a better chance to actually work. Without dry mopping, you are not going to have the same effect. Absolutely required. Bathrooms. You have to disinfect toilets and drains because biofilm can come up from the drains, and when you flush a toilet, there are many studies out there that show that circular process is aerosolizing pathogens. So you need to use a certified endless disinfectant, get it in the bowl, and disinfect that toilet, and then you're going to be in a safer position. And this is key. All single-use products should be considered contaminated and disposed of appropriately. You don't be dragging this stuff around your building. Make sure it's disposed of appropriately at the scene of the cleaning. After you've done cleaning, you got to disinfect your equipment. You have to doff your PPE, and you have to do hand hygiene. Now, we'll talk about this in a second, but enhanced disinfection is absolutely a best practice. And it does not replace cleaning and disinfection. There are many types out there, whether it be UVC, chemical, fogging, misting. Bottom line is, use something. We know from the process that we've showed that disinfectants may break down. We'll talk about what percentage of the surfaces a housekeeper actually misses. But this is an insurance policy after general cleaning that's going to give you the best opportunity to remove all the active pathogens that are out there. Now, some high-risk tasks to consider in this COVID-19 environment. Everyone's at risk. It doesn't matter where you are. But certainly as you have confirmed cases, whether it be residents, students, patients. We got to look at some of the tasks that we've done and understand, are they creating greater risk for us? Regular vacuuming. Vacuuming is going to aerosolize pathogens that are rested on the floors. You should have a HEPA filter vacuum is the best practice by far. If you're doing burnishing, that also requires a HEPA filter. And certain floor tasks may be discouraged if you can't pre-clean with a disinfectant before, make sure you're dry mopping and damp, disinfecting with a single-use microfiber, and then, with a HEPA filter. But again, understand if you have an active patient in that area, in that room, and you're going to have to mitigate through those processes. Certainly linen replacement, cubicle curtains, bed, and then dusting in general are things that you have to consider as a risk. So training and competency. This is some of the most important aspects that a lot of times we miss. So you cannot expect to teach these employees that are paid $11 or $12 an hour, give them the keys, give them the equipment, and just send them out to do their jobs. You have to do a classroom training to understand why this is so critical, that they are one of the most important people in this fight. They need to do hands-on training. You need to observe them and then correctly retrain them as needed. Then you got to go through a validation process, and then you continue the circle again. It's continuous retraining and validation to ensure that everyone is doing what they should be doing to all the surfaces all the time. And it includes hand hygiene, PPE, and the cleaning and disinfection. So let's talk about the best-in-class innovations, just a few of them. We talked a lot about single-use microfiber. This is absolutely a critical aspect. You don't want to be dragging contaminated mops around, and these are by far more effective. They eliminate the cross-contamination. They're more effective at pathogen removal. They dramatically reduce water consumption, and believe it or not, they're far more environmentally friendly to just throw them out on the scene than to try to go through this huge laundering process using tons of water, tons of chemicals, and they still may come back contaminated, or the catch-22, you may destroy them. You should be using them for dry mopping, damp mopping, and all surface disinfection. Here's an example of a product that we did in a simulation lab with actually C. diff spores. We compared the Trust Medical dry mops and wet mops compared to laundered microfibers, and you can see 78% of the pathogens were removed from the surface versus 14% on the launder, and 21% on reuse or single-use dust cloths that you see out there. So far more effective in removing these. Endless disinfectants. From the right, you have single-use disinfectants, single-use wipes that have a 1-minute contact time, the Oxivir line. And then you have an endless Defender single-use wipe application. But I would also remind people that, especially in the hospital environment, we're still dealing with C. diff. We're still dealing with Candida aureus. And the good thing about certain disinfectants such as Defender is it appears both on the N and the K list. So the K list being a sporicidal disinfectant. It has the first EPA biofilm claim, a lot safer. It's an alternative for bleach and can be used as a wipe. So let's talk about enhanced disinfection. It's a critical step. If you look at the amount of pathogens before cleaning, we know when we clean, we're going to remove about 50% of those pathogens. And I'll get to the reason why there's still about 50% in a minute. But the studies show that only about 50% of the surfaces are actually wiped by a housekeeper on a daily basis. By using enhanced disinfection, we can bring that bioload down below 1%. So this is just one example, and it's critical that this is a critical step in the process, no matter what environment, whether you're in a hospital or a school or college or a corporate environment. We're starting to hear a lot about continuous disinfection, antimicrobial surfaces, oxidizing molecules that really organically fill the air, replicating what's outside on a sunny day in a normal environment. HVAC and water-based systems that actually, if you see the graphs on the right, can dramatically reduce within 6 hours the level of pathogens, and these type of devices work 24/7. So let's talk quickly about assessing the environment, and then we'll get into our Q&A. So you really need to understand where you are. How effective are you at your cleaning process? So the environmental risk assessment, you need to review your cleaning and disinfection process as we talked about. You need to look at what is your inspection process, and you need to, whatever you find, those become the foundation of your process improvement plan, and equally important, your retraining your staff plan. So as I talked about earlier, looks can be deceiving, and Rodney had talked about earlier that you can't see these organisms. So we've been taught as an industry of cleaners to visually clean. The challenge is what you don't see is deadly, and you need to focus on more effective process. So we need to change the industry from visual inspection to actually biological. So this was actual study of 50 facilities where Dr. Philip Carling evaluated housekeepers in 50 buildings in the New England area. And amazingly, they found out that 51% of the surfaces were not even wiped. And the reason being, and I can tell you as a housekeeper, we are visually cleaning on a daily basis. In most inspections that we do, the supervisors come around, we just look around, yep, oh, looks good, good job, Johnny, and then we move on. We need to get better understanding of the biological impact. A simple tool that we put in place is a black light testing. Now, this is simply putting an invisible marker throughout the facility, and when we do this, we increase the effectiveness of cleaning from 50% up to 90%. It's a non-punitive thing. You help the cleaner to understand, hey, you did a great job on half of these surfaces, but look at these ones that you missed. You missed this doorknob, you missed this sink handle, and we know that thing is touched many times a day. It's a simple, cost-effective educational tool to teach people how to wipe all the surfaces all the time. Biological testing is something we all need to move to. We need to understand what is still active in that environment. Now, this might not be practical on a daily basis, but it should be part of your process improvement plan to continuously look at evaluating what's there. You simply do a sample testing and do a swab, and you send it into lab, and it will tell you all the surfaces, what you have, how many colony forming units. This is the only way we're really going to know whether we're having effect. In a lot of facilities I've worked with, we do this either monthly or quarterly and make it part of the process improvement plan. Okay, I'm going to turn it back over to the moderator where we're going to talk about some of the tips, resources, and next sessions, and then we'll get to Q&A.
Thank you, John. So TIPS has assembled a wonderful resource page for you. It's here on your slide, infectioncontrol.tips resource page. And Michael Diamond has done a great job of collecting the most up-to-date information and putting it here for your one-stop shopping. So feel free to check that out. You will also find all the webinars that we've done archived on the TIPS website. Someone was just asking about the part 1 of this series. It's not up yet, but it will be, so check back with us. But here are all the free services that TIPS can offer to you. So our next webinar will be tomorrow. We're going to, on April 1st at 11 a.m., the webinar topic will be N95 respirator use, disinfection, and reuse, what the literature says. So I hope to see you there. Thank you both, John and Dr. Rohde for this excellent and very informative presentation. We have received several questions, so let's get started. Our first question, Rodney, please clarify on surface-to-person transmission, the virus lasts for 3 to 7 days on surfaces?
Could you repeat that question, Katie?
Sure.
I'm sorry.
No, that's fine. So please clarify on surface-to-person transmission, does the virus last for 3 to 17 days on surfaces?
Yes, that's the current study that came out in about a week or so ago that looked at that. Again, I would iterate that this is not unusual. If you look at other viruses and other microbes like bacteria and so forth, many things definitely can withstand the outside environment for hours and up to several days. What's important for the audience to understand that many times you don't get in an article or on a popular type of article is that there are a number of important factors that aren't discussed sometimes, including the amount of organic material that's around that organism. So if it's a body fluid, for example, then that organism is going to remain more viable for a longer time. So if you could imagine, say, a handkerchief that sneezed into, that organism would be viable longer than if it was just on a dry surface. The humidity, the temperature, even sunlight that has UV light in it can be part of the survival stability of any agent. But that's what the research is showing, roughly about 3 hours up to 17 days at this time.
Okay, thank you. And Melinda asked, when you say that COVID-19 can live on surfaces for 17 days, is that from the Diamond Princess CDC study? Or are you considering the presence of viral fragments as compared to infectivity of the virus?
I'm sorry, I can't quite hear your question, Katie.
Sure, let me repeat it. Is that better?
Yes.
Okay. When you say that COVID-19 can live on surfaces for 17 days, is that from the Diamond Princess CDC study? How are you considering the presence of viral fragments as compared to infectivity of the virus?
So that's the golden question. That is still being looked at. Viability, that's one of those factors I was kind of mentioning. Viability is simply, can you find it there and being viable? So viruses need a host to actually reproduce and survive, but they can remain viable for that amount of time is what they're finding. The infectivity are studies that are still being kind of discerned. In other words, if you take a particular surface and swab it and then put it into cell culture to see if that virus can actually amplify and infect, those are ongoing studies, and so that information is being discerned right now.
Okay. John, I have a question for you. Do you believe cleaning or disinfecting extra vigilance will continue past the COVID-19 pandemic?
Well, that's the absolute hope, and I believe that everybody on this call needs to become an ambassador to the cause. You know, the only way we can affect change in our industry is for everyone to demand that the changes occur. We know the science is there, we know the research is there, and we know the results are better if you follow these directives. So that's the goal, that's the objective, and I do believe that we are absolutely going to change, and we're already seeing that. This is going to, we're never going to get back to where we were.
Well, John, there's a question that might be more rhetorical from Elaine that I think she would agree with you. She said, I understand the cleaning and disinfection process is a recipe requiring participation from everyone. With the enhanced disinfection practices, why are hospitals/buildings slow to use these types of technologies to get ahead and slow the spread of COVID-19? With UVC light, why can't hospitals install these lights as soon as possible?
Well, I think you're seeing the increase right now, and unfortunately, similar as I talked about, it sometimes takes a 9/11 event to get to that extreme, and I believe that, you know, we all need to, and again, tips and HITS and other groups that are focused on this mission to improve our industry are going to try to push for greater regulation, greater guidelines that focus on cleaning, disinfection, and absolutely enhanced. I mean, we can't expect housekeepers to do this alone. We have to give them all the technology and give them the best chance to give us the best outcome.
Thank you. Here's a question about biofilms. It says, I agree with biofilm and bacteria. Any studies showing viruses and biofilm association?
I haven't seen a ton of those types of articles coming out right now, other than finding viruses in body fluids and things like that. My understanding, it's primarily bacterial and fungal types of biofilms that you typically see. Remember, viruses cannot live without a cellular type of host, so it needs to be in some type of living organism to survive long term. Thank goodness.
Thank you. Here's a question/comment. The people in sterile processing world are concerned that decontamination areas, contaminated surfaces can become aerosolized again. Is that a greater threat than fluid splashes, as the current guidelines call for fluid resistant mask rather than the aerosol risk from aerosolization?
I mean, I think you'd have to know the very specific tasks that they're performing. Certainly in the sterile processing environment, they're moving a lot of material and equipment around. There absolutely can be a risk for aerosolization and splashing. So sometimes this is what I referred to as the common sense. Sometimes the research and the proving of what is exactly going on in this environment hasn't caught up to what's really practical and common sense. You know, I would err on the side of caution that if you're performing a task and you believe it's being aerosolized, then get that N95 on, because you are going to be at risk.
This pretty much wraps up our time today. So we want to thank our presenters, Dr. Rohde and Mr. LaRochelle. Thank you so much. And thank you all for attending today. Remember tomorrow's webinar, tomorrow, April 1st at 11 a.m. Eastern Daylight Time. Again, the topic will be in-home respirator use, infection, and reuse, what the literature says. I hope to see you there. Thank you.